Larkin Community Hospital has had a phenomenal success. It is the largest osteopathic hospital in the country. Last year, 8,000 patients visited the ER. We had 6,000 admissions. We had 800 inpatient surgeries. We had 750 outpatient procedures. This year, we are on track to double those numbers with over 300 residents and fellows, extending from cardiology to GI to internal medicine. Larkin is committed to providing innovative healthcare, teaching the community, and being a leader in medicine and dentistry. We embrace this opportunity, and I assure you that during the next 3 days, you will learn advancements in endodontics and other subspecialties of medicine and dentistry.
Just a few words, just to express the gratitude on behalf of the Peruvian government to the Larkin Hospital and the Tracy community for the opportunity that in this moment to give this symposium to the Peruvian doctors and students of the University of Garcilaso de la Vega, UPC, and Cayetano Heredia. Thank you to Larkin and Larkin Hospital and Tracy community. I hope that it's not the first and the only event. I hope that in the future we can see here more doctors and students from the Peruvian University. Y que tengan éxito. Felicitaciones a todos. Gracias.
I'm sure that you didn't expect a neurosurgeon to start off this program. I'm going to talk to you about something I think is very relevant to the dental practices of oral surgeons, orthodontists, dentists, which is trigeminal neuralgia. And the reason I say that is after over 1,000 cases with gamma knife radiosurgery and 500 microvascular decompressions, looking at least 30% of my patients who have had multiple dental procedures performed on them that were clearly not necessary, procedures that could have been avoided, and thereby people that wouldn't have been as angry with their dentist or their oral surgeons as they wound up being after they understood that their diagnosis was never a tooth problem, but actually a nerve problem related to their trigeminal nerve. It's not a discovery that has been, newly done. This is a French surgeon, Nicolas André, describing what trigeminal neuralgia really is, which is a sudden wincing contraction of facial muscles in response to severe pain or tic douloureux. That was one of the first descriptions of this disease. And the most important aspect of this is that this is a clinical problem. There is no way to diagnose this with anything other than your clinical acumen and an understanding of what the patient really has. Now, trigeminal neuralgia is an intermittent paroxysmal pain. So almost always the way this starts is a sudden onset of pain out of nowhere. And for the longest time, it comes and goes. The patient never describes chronic pain. The patient will not describe losing sleep over this pain. Most of the time, these patients can actually fall asleep, as opposed to patients that have chronic, ongoing dental pain that almost makes it impossible for them to get to sleep. The mean incidence is significant, 4 out of 10,000. Most patients, over 60%, have the pain on the right side. 60% of patients are females, and over 90% of the patients are greater than 50 years of age. So it's not usually a young man's problem. It's important for you to understand the features of the pain. This is incredibly severe pain. It's lancinating and shock-like in quality. It can be spontaneous, or it can be triggered by touching the face, brushing their teeth, eating. Even the wind can set this off. So there are temporal features. This is brief, usually a few seconds, lasting a few minutes. It's intermittent but recurrent. The pain can recur after a few months. It can recur even after a few years. So it's something to keep in mind in patients that say that 5 years ago I had this and now I have it back. That's not a dental problem. All right? Less than 10% of these patients will experience this before the age of 50. Now, the differential diagnosis for trigeminal neuralgia is very large. But you have to remember that this is really a clinical problem. And so most of the time, you will have gone through all kinds of tests that are negative, including x-rays, panoramics, MRI scans, CT scans. So even though you have this large differential, if you understand the clinical symptomatology of lancinating paroxysmal pain that is either sharp or electric, and you have negative CT scans, negative MRI scans, negative panoramics, you have the clinical diagnosis, and that's really what you need to know. So modern therapy today consists of pharmacotherapy, destructive procedures, and non-destructive procedures. Now, if you see a patient like this in your practice who comes in with an unusual severity of pain that's lancinating and paroxysmal, and they have negative x-rays, panoramics, negative root canal x-rays, etc., those patients respond really well to medical treatment. And my favorite still is Tegretol or carbamazepine. It's cheap and it's the most effective, the easiest to give these patients, 200 milligrams PO/BID. For the majority of these patients, 80 to 85% of these patients will call you up within 24 hours and they're in love with you because their pain is gone. Then we have injections where we do peripheral injections with Novocaine, Marcaine, combination of steroids. Avulsions do exactly the same thing. The next step that neurosurgeons can take are percutaneous procedures, okay, where we can do a microcompression of the trigeminal nerve through a needle taken to the trigeminal ganglion. We can do a percutaneous glycerol injection through the same needle, or we can do a thermocoagulation. And these are, in fact, very effective at taking care of the pain. The problem with these procedures, all these percutaneous procedures, is that the morbidity is a bit high. So the main requirements of any neurosurgical operation for the management of pain has to be safe and of little stress to the patient, a very high success rate, with relapse rates and complications that are acceptable. Otherwise, you're not providing anyone a service. So let's talk about gamma knife radiosurgery. Radiosurgery is the administration of a single high dose of radiation. It's a single treatment, all right, localized to a very, very small volume, all right? Gamma knife can do that. Very few other machines can do that. Now, you need a very steep dose gradient. You need to have the radiation fall off very rapidly because, as I said, you're going to have a target that you're going to administer a very high dose of radiation. Well, obviously, in the brain, you don't want to do that to a very large space. So we affix a stereotactic frame on our patients. Over 95% of our patients are done under local anesthetic with IV sedation with propofol and Versed. It takes about 3 minutes to put on the frame. Now, what's the evidence that this works? Well, when you look at Young et al. From Washington on the gamma knife treatment for trigeminal neuralgia, 312 patients, excellent 66%, good 29%, for a failure of 5%. That's an excellent outcome, better than medical therapy. When you look at the group in Phoenix, Arizona, in 43 patients, 22 of them who had had prior treatments, they had initial pain improvement in 97% of these patients. In our first 6 years, we treated 355 patients. As I said to you, the majority of them female with a median age of 69. With one treatment, we had excellent results in 89 and no improvement in 15%. When we did a second treatment on these patients, we had 33% with excellent and 46% with good, so that in essence, at the end of it, we had 90% with excellent results and 7% with good results. The fact is that the advantage of the gamma knife is that if it doesn't work, we can always do the microvascular decompression, and we haven't broken any bridges or any pathways. Anyway, I want to thank you very much for this opportunity, and if you have any questions, feel free to ask.